around, it's not that unusual to assume that that would be that way, because it's only fairly recently that the whole skin to skin thing with normal vaginal births has really become, I'm old, I'm her mother. So I had 3 C-sections, and I was lucky enough to be able to labor for all 3 of them. But the whole natural birth thing is relatively recent, so that it would take the surgical aspect of birth a little while to catch up with that. I think it's not difficult to believe. I think it's great that there's this excitement about it. I think it's fantastic.
Yeah, I'm glad to hear the story. Thanks for sharing it.
I have just one more question. As you know, I'm one of the physical therapists who treat pregnancy. And a lot of times I get patients who have breech babies, and I teach them to do the polar bear technique or the inverted position and have a great success with that. My question for you is, do you have a recommended amount of time that they should stay in that position? I tell them a couple minutes a day or whatever, but I wasn't sure what the exact time.
Yeah, I don't particularly offhand, but doing that 2 to 3 times a day rather than just once a day at least is what I would say.
Yeah.
And the earlier your clinician diagnoses breech, the better. Because you start those exercises at 34 weeks. Like, just to find out at 37, you got a much bigger baby already.
Right.
Like, the earlier you know, the easier it is to turn. And we do external cephalic version, by the way, also for folks who those exercises are not successful for, or moxibustion, acupuncture, seeing the physical therapist again, going to a chiropractor. I mean, I have a list that's like
I'll
a mile
refer
long.
them out for that stuff.
What's that?
I will refer them out like to the chiropractor, acupuncture, but I try to start them as early as possible.
Yeah.
And because they'll start telling me I think I'm going to have to have a C-section, I'll say to them, no, I don't think you have to. We can just get the baby to turn.
Right.
So, and usually it's a good success rate. I just wasn't sure how many times a day you recommend it.
Yeah, I usually follow suit with what you guys tell me, to be honest with you.
Okay, because I tell them like 3
this is a
times a day.
collaborative care. You know, when a physical therapist says to me, I see no problem with the patient doing it 5 times a day,
Okay.
you know, I don't either. Like, I can't think of physiologically why that'd be a problem. So
I just wasn't sure on the inverted position if there was a problem.
yeah, no, because you know, and everyone says that with yoga positioning too. Like, if you're in an inverted position, you know, could that cause harm to the baby? What if I wake up in the middle of the night, I'm laying on my back?
I know that's fine.
It's okay.
I know that, yeah.
You know, people get worried about, they're not on their heads, right? And they're not holding.
Right.
And frankly, I think babies are brilliant. Like, they tell us that they tell you to move. Like, and they tell you in a way that probably with decreased blood flow, they start to move in a way that's uncomfortable. You naturally shift your weight.
Right.
You wouldn't stay in a position where that baby was in trouble. It doesn't make sense.
That's a good question for you, and we've talked about several times. What I usually tell my patients the exact same thing, that they come to me and they say, I woke up on my back this morning.
It's no big deal.
So, if your body was not comfortable being in that position, then you would not have woken up that way. You know, like that is that pretty much what you say? Because sometimes I'll even have a patient lie on their back on the table to check a couple things, or I'll say, this is how I want you to contract your abdominals when you're going from, lying down to sitting up, and you're like, well, I can't lie on my back. But, I mean,
I'll tell them
Which
to
is
get
so
that.
hilarious,
I'm like,
think about traditional labor, and then women on
Yeah.
their back, and
Right.
then
For
now
hours.
suddenly it's all right. I mean, it's
exactly. So it's perfectly
I mean, it's not always nice to bolster that left side, and just to get them off the inferior vena cava. We do it during cesarean, and we do it if moms want to be in that position. Say they have an epidural, it's been a long labor, they want to rest, and recommending that they just bolster themselves up just for blood flow to the uterus, and that's really it. I mean, you can be on your back.
Yeah.
It's,
I was nice to see.
if there are things to be alarmed about, that's not one of them, right?
I just wanted to also share that we had a gentle cesarean with Dr. Morton a month ago today, and I was attempting for VBAC, and my daughter's 5, and it didn't work out that way. And my cesarean with my daughter wasn't terribly negative, it really wasn't. I had a woman and infants, and breastfed well, wasn't depressed, anything like that. Actually, she latched on sooner and more effectively than he did, although that was like just within a day, and he's nursing like a champ. But the experience was amazing, and I just can't, I don't know, it was so satisfying, just the whole thing. I think I just wanted to come out and support what you guys are doing, and
Thank you. You guys think that make me cry. I'm such a sad. Who knows that I cry all the time.
Breech birth has come up a couple of times, and it's also been in the news a lot lately in regards to Canada and the U.S., and I'm just wondering if there's any talk of vaginal breech birth around in Rhode Island. section, which then makes it more difficult if the woman wants to get a VBAC or, you know, there's complications with subsequent cesareans. I'm just wondering.
I mean, the pendulum always swings back and forth. So there was a time where vaginal breech delivery was a normal thing in the United States, and what they found was that there was a higher risk of sort of bad outcomes with the babies. And so after a while, with sort of more and more information about that, they sort of limited vaginal breaches to twin second deliveries. So we still do it in emergency situations. And silly enough, we've done 2-term vaginal breech, 3-term vaginal breech deliveries in Memorial in the last
4 months.
6 months.
4 months, really.
Yeah.
It was a little.
So it happens in emergency situations. It can happen for a second twin, but as term, it has a lot to do with hospitals again, feeling comfortable with that and what potentially.
And training. I mean, you have to remember that, you know, I grew up in the training, when I was a trainee at the time of the term vaginal breech trial that came out in 2001, right? So it was right at the time when they were saying nobody's doing this anymore. I have never done one except not on purpose in an emergent situation. And
Which
I've
is
only done
worrisome
one.
because if we want to go back to doing vaginal breech births, we have to, you know, go to another country to get
To
the
learn.
skills.
Oh, I
Because
absolutely
all of
believe
the
that.
practitioners who were skilled at breech deliveries back in the 50s, 60s, 70s, whatever, are retired, dead, you know, out of practice.
Well, Dr. Ward, you said, I mean, I feel like one of the because I asked everyone in vaginal breech because this is my second, and my first one was so smooth. It was like such a shock to think I would have a cesarean. So definitely grilled everyone, including you. And, I mean, you said a lot of it was malpractice, though, too, because you know how to do breech. You've been trained. That wasn't the issue. The issue was malpractice, right? And that I have 18 years to, you know, I said, I'll sign away. I will not sue you. I'll sign pieces of paper. And you said that's not going to hold up in court because you're the expert.
And it's
I'm
not
the
like
patient.
John.
Even if I sign something,
Right.
you know, they would find in my favor, and there are a lot of reasons why I could change my mind. I mean, you know, I don't think I would. Why one might change their mind, either the pressure from family or pressure for money, or why people sue. You know, why this country's so litigious. And so, until that, and until there's change there, it's probably not going to be big. We're not going to see big changes in at least a hospital.
Yeah, and I agree with you. I think the malpractice thing is one of these things that looms large for people and has lots of negative impact on lots of people involved. And so, and hospitals, again, you know, is trying to run an institution and stay financially solvent, you know, having a multi-million-dollar lawsuit can cripple them very easily. And so we've also seen situations, we have one in Rhode Island where hospitals are, you know, in danger of closing because financially they can't really solve it. So, you know, there are a lot of factors that go into those particular policies and whether an individual hospital, you know, wants to recommend it or not. I think in the, you know, in terms of ACAN is not supported at this time, but with lots of things that the pendulum just changes with more information and with data. So.
Right. I mean,
The training piece, though, because I've talked to obstetricians who, for even a second twin, who where ACOG says that that's fine, hospitals have no problem with it, and I've talked to obstetricians who have said, I believe that it's safe, but I did 2 breech deliveries in my entire residency, and so I don't feel comfortable doing it. And I've seen that happen too, where even an obstetrician who feels that it's okay to do, and the institution supports it, the second twin.
Meal like that, why wouldn't they call someone in to?
Well, that's
do
been
it?
discussed, and that's where that's the kind of the setting that I'm talking about. A group of physicians talking amongst themselves. Well, you know, can we guarantee this to the patient? Because does everybody in the group is everybody on board with being able to do this? If you're the one on call, and if not, who will do it? And it's been that kind of discussion. But that's what I was struck by. You know, doctors who would like to do it, but just don't feel that they ever had the opportunity to get the right training for it. Because they're so rare now.
Yeah, that's an interesting thing. I mean, in my training, whenever there was some interesting skill that was one of those older skills, then there were always people in the hospital system who knew how to do that, who would then sort of, with the patient's consent, really provide this tremendous teaching environment, you know, so that those things could happen. And a lot of times in the MFMs, there were the high-risk OB specialists who were trained to do a lot of those things as well. not just general obstetrician gynecology specialists who do more specialized kinds of care. And so it's surprising me that a big tertiary care center doesn't happen, because then the experience does exist.
It definitely happens, but you run into individual physicians who don't feel comfortable doing it, even though philosophically, medically, they believe that it's safe.
Just thinking about my experience, you may have mentioned this, but when there's a lot of meconium and that's an issue, I mean, do they just handle it and then do the skin to skin, or is it just how does that?
I think in a situation where there's a non-vigorous baby, so right now the American Academy of Pediatrics recommends that babies who have meconium and are non-vigorous at birth. So that still means that you can do that delayed cord clamping and spend that 30 seconds assessing that baby, and if it's non-vigorous, we would still recommend that baby be brought to the cooler, to be intubated for meconium. So when they're intubated, the meconium is suctioned out, and then they are stimulated and could be placed immediately on mom's chest after that. So we have had one so far where we needed to do that.
What is the non-vigorous? Just means they're not like.
Non-vigorous, their heart rate's less than 100, they're not breathing and not moving.
They come out and they go.
Literally, they flop over like that. Like, it's very obvious. To mom and partner and doula and everyone in the OR. Well, a non-vigorous baby is not like, oh, is it vigorous?
Yeah.
No, maybe. I mean, it's not like that at all. It's like black and white. It's very obvious.
And have you had any issues with doing skin to skin with meconium baby where then they have to stay longer and that stuff?
No. I mean, well, if a baby has meconium stain and cries immediately and is vigorous, it's nothing to do. I mean, there's nothing to do but normalcy. So to get that baby on mom's chest, and it wouldn't. And have we seen babies who then have meconium aspiration syndrome? Yeah, but the process of going skin to skin in the OR had nothing to do with that, because it's not indicated to intubate and suction that baby anyway. Okay. So whether it's then stimulated on a warmer or up in the air or down here on mom's chest doesn't matter at that point, because the baby kind of sucked it in his or herself. You know, there's nothing you can do at that point. And those babies tend to do just fine. Meconium aspiration syndrome is rare. It's not common. Yeah.
I'm just going to bring it back to mushy squishy.
Okay.
I just wanted to say, I don't know, kind of on behalf of a lot of us in Rhode Island, that it's just amazing that there's a place where women can go, where they don't have to fight for any of this. We can direct moms that want this kind of experience to say, go to Memorial, because you're going to get that care.
Memorial was
You're not going to have to
It was amazing. From the nurses, it was unbelievable. And I birthed at Women and Infants, and what I say is it wasn't bad. I mean, it certainly wasn't bad. I'm not bashing them at all. But if I have another baby, sign me up. I'd love to go into labor naturally, even though I'm sure after 2 cesareans I would have to have another one. But I'm one of those that I think right. But I don't know if I'll have any more. But Memorial was, it was amazing. Everyone, the nurses were fabulous. The anesthesiologists were awesome. They were like talking to me, and I could like feel things during and they were all. It was funny, but it was fine.
I'd love to study that, because women do sometimes
feel
things. The longer your C-section lasts, the more likely they're going to start feeling things.
Yeah.
But what if that baby's
No, it was fine.
They're probably not going to be like,
no.
wait, I'm feeling something.
Yeah.
And they're distracted.
It was. Yeah. I was not as painful as labor contractions. I'm like, I feel something. It's not taken from my experience.
And you could talk to the people there and saying, I'm feeling something.
Yeah,
or
that's what I did.
Talk to the surgeons in the middle of it, or, But I do think that having a baby on your chest is probably lowering your pain scale. Nurses are like, how much pain are you feeling? When you're holding your beautiful, miraculous baby, you're not going to say 10 out of 10. I don't even care who you are. You're just not.
There was, just another mushy squishy comment that